Hi, my name is Alicia Gonzalez, and this is my presentation assignment for Kinesiology 3347. The study that I chose to review was called Risk of Malnutrition and Health-Related Quality of Life in Community Living Elderly Men and Women, the Tromsø Study. This study was published online November 13th in 2010. It was an article from the Quality of Life Research Journal, and the researchers were from the Department of Community Medicine, Department of Gastroenterology, the University Hospital of North Norway, Laboratory of Gastroenterology and Nutrition, and the Institute of Clinical Medicine, all in Tromsø, Norway. And I've included the link below in case anybody would like to check out this article that I have used. The purpose of this investigation was to investigate the association between the risk of malnutrition and body mass index, as well as health-related quality of life, which body mass index is abbreviated to BMI, as we know, and the health-related quality of life is the HRQOL in elderly men and women. So in the most affluent parts of the world, oddly enough, malnutrition is a very large and growing problem, and it is related to other diseases such as cancer, arthritis, and sarcopenic obesity, just to name a few. This specifically affects older adults more than any other age group, which was very intriguing to me. So over the past few decades, health-related quality of life has been utilized as a measure for comparing health statuses and has revealed a strong correlation between morbidity and mortality in elderly people specifically. In this study, malnutrition was viewed as a factor that not only affects how long a person may live, but the quality of that life as well. And I was personally interested in this article because my own grandmother is aging slowly and her nutrition is not the best. And as a future healthcare professional who wants to go into physical therapy, I think it is super important to advocate for nutrition and activity for not only rehabilitation, but supporting quality of life in all patients as well. The design of this experiment was a cross-sectional population that was taken between October of 2007 and December 2008 in Tromsø, Norway. 1,632 men and 1,654 women were recruited between the ages of 65 to 87 years and were tested in a center. Other variables such as education, income, and smoking habits were also documented later on at the center as well. Body mass index and the quality of life were evaluated primarily, and then two separate tools, which I'll discuss later, were utilized to determine the risks of malnutrition. The participants, in order to participate in this study, had to be permanent residents in Tromsø, Norway. They also had to be greater than or equal to the age of 65 and had to be independently living, meaning they could not be in assisted living homes or nursing homes or anything of that sort, as they had to independently be able to visit the research center to complete this study. A self-administered questionnaire over involuntary weight loss within the past 6 months was also given to the participants, and they filled that out before their calculations were taken. There were a couple exclusions, as certain people could not have their height and weight taken due to disabilities, and 412 people as well were missing the weight loss information. They just did not fill that out. An additional 298 people also just did not respond to the survey that was given to them. So the second part that I'm about to discuss only had 1,306 participants. The measurements of this study were conducted at a research center, where their weight and height of each participant was measured using the stadiometer. Body mass index was calculated as weight divided by the square of their height and categorized into the World Health Organization's 6 categories, which range from normal to obese. And here's where the weight loss questionnaire was also self-administered. So based on this BMI and weight loss that was reported, each subject was then categorized into low, medium, or high risk of malnutrition according to the British Malnutrition Universal Screening Tool, abbreviated as MUST. The quality of life was also measured using the EQ5D instrument, which is a self-assessment in which participants then were told to rank specific dimensions of their daily life, such as mobility, self-care, unusual activities, pain and discomfort, and anxiety and depression. And each dimension was then subdivided into 3 different levels, being no problems, some problems, or extreme problems. In addition, participants rated their health on a visual scale where they discussed their worst imaginable health state and their best. Questions such as their health history, current status of activity, and emotional well-being were also asked at this time. Risk categories of malnutrition were further analyzed by gender, but BMI did not seem significant enough to rank by gender or sex. And differences between these groups were then mathematically evaluated using a chi-square test or a t-test when appropriate. The results of this were that the average participant was around 72 years old, and more women than men were at risk of malnutrition, as their quality of health was then lowered because of this. For men in the high risk category, however, the strongest association was found in self-care, which was very interesting to me. Overall, most participants reported one of the health problems in this dimension. And with increasing risks of malnutrition, problems in all 5 were reported more frequently. To sum it up, the quality of life was significantly reduced in elderly people at an increased risk of malnutrition, and this was more pronounced in men than women. They were found moderately in overweight individuals, and this concludes the study as saying that malnutrition affects the mental health of elderly individuals, which decreases their quality of life, which also malnutrition also decreases their quality of life as well. So that is my presentation for Kinesiology 3347. Thank you.